Welcome, everyone. Welcome to this SSA-themed session on comorbidity. I'm absolutely delighted to be talking and chairing this session today because it's an area that I come across clinically every day, which is the issue of people who have developmental disorders and also an addiction. My name is Owen Bowden-Jones. I'm president of the SSA, and we've got three exceptional speakers today. What I'm going to ask is if you keep your questions until the end, and what we'll do is a panel session after all three speakers have spoken. So let's move straight on. Our first speaker is Professor Wim van der Brink, who almost needs no introduction, I'm sure, known to many of you today. Wim is the Emeritus Professor of Psychiatry and Addictions at the University of Amsterdam, the previous Director of the Amsterdam Institute for Addictions Research, and the President of the International Collaboration on ADHD and Substance Abuse. Wim, the floor is yours.
So thank you very much for the invitation, and Sarah Welch, who arranged everything for us after a meeting of the SSA. And so it's a pleasure to be here again and talk about a little bit about ADHD and substance abuse, but also about the ICASA, our collaborative activity, and just also to try to inspire you that even without a lot of research money, you can actually do quite interesting things if you start to collaborate and not to compete. Let me see whether, yeah. These are my disclosures, and I think none of them is really relevant today. I want to say a few words about the ICASA, the organization, its mission and studies, and then after that talk a little bit about some of the findings that the studies that we did with that collaborative network, what our main findings were. So first, the mission of ICASA. This is, we wrote it down, and we were able to publish our initiative in European addiction research in some 4 or 5 years ago. And we started the international collaboration of ADHD and substance abuse in 2005, and we're an official foundation located in the Netherlands since 2010. And currently we have 59 participants from 29 centers in 17 countries, and so the network is growing. And our original mission was to, and that's quite something, to decrease the risk of ADHD patients developing substance use disorders, and also to improve the detection, diagnosis, and treatment of patients with substance use disorder and a comorbid ADHD. And in order to do that, we thought that we should come together and discuss these issues, but not only discuss it, because we didn't want to become a talking group, but we decided that we should do some studies to bring these goals a little further. And for that, we did 2 epidemiological studies. We developed consensus papers and to see how we can treat patients with substance use disorder and ADHD, both adolescents and adults. And recently, we finished a treatment and prediction outcome study in patients with substance use disorder and ADHD. And I will talk about these studies a little bit later. So what are we doing in this network? In this network, it's a non-profit foundation in the Netherlands. And we have members, and members are not individual persons, but it's an institutional membership. And we only accept members with a clinical expertise and research. So pure research is, it's not the place in ICASA, but it's really this practice-based research that we're looking for. We have a membership fee. It's about 3,000 euros per year. But of course, if we come from countries where that is a lot of money, we of course start talking with people. Our activities is in-person meetings once, twice a year, including writing sessions, because we do studies, and the studies have to be written up, and not all clinicians are expert writers, so we try to support people to write up the results in writing sessions. We have online meetings also, once, twice a year. We do perform the studies, and we publish studies on these issues. And while we have these in-person meetings, we also organize symposia presenting these results on these meetings and just spreading the gospel. So substance use and ADHD, this was actually the start of ICASA, that we did a large systematic review and meta-analysis, and this study was published in 2012 only. We did, there were 29 studies, including almost 7,000 substance use disorder patients, adolescents and adults, and the overall prevalence of adult ADHD in substance use disorder patients was 23%. 1 in 4, 1 in 5 patients coming to treatment had an adult ADHD. Now, there was a problem. It were mainly studies from the US, and there were very different diagnostic procedures. Recently, this similar study was done in 2023, and the prevalence in that review was 21%, so very close to the 23% that we found. But still, there was a problem of all these using these different measurement procedures. So that's why we started, as an ICASA network, we started the International ADHD and Substance Use Prevalence Study. And this was the study. We were looking at the prevalence of ADHD in these substance use disorder patients. We were looking at the prevalence of additional comorbidity. We were looking at the reliability of screening instrument, in this case the ASRS, and we were exploring risk and predictive factors. And it was a cross-sectional study in 10 countries with identical instrument in all countries. So to solve this issue of measurement variability. The sample size and the main findings are that we were able to collect almost more than 3,500 patients in which we could take the screening, and in 1,138 of these, we also did a fully structured assessment of the ADHD symptoms with the CADIT. In this study, about 40% of the SAD patients were screen positive. That's not the same as having the diagnosis. So we started to look at these, the screener and the quality of the screener. And what we saw there is that if we use the CADIT, the structured interview, the prevalence was about 13%. And remember, the screening positive was 40%. So you see, it's not so easy to just use only the screener. And here you see the data from the analysis, and you see a negative score on the screener makes you almost sure that people don't have ADHD. You have a negative predictive value of 98%. But if you have a positive screen in a population with 13% prevalence, the increase in the prevalence and the chance that you have a patient that really has ADHD is only 28%. So every positive screen has to be followed by a diagnostic interview. But having a negative screen in any stage of this procedure, and you have a negative screen, then you can be sure that there is no ADHD. The prevalence, we looked at the prevalence of ADHD, and again, we had quite a different ranges in the different locations where we worked. There were places where ADHD was prevalent only in 5.4% in Norway, and we have an Hungarian site where it was 31.3%. We decided not to give an overall estimate in that sense because the settings were so different. We looked at DSM-4 and DSM-5, and I must tell you, this is a lot of hassle that everybody does with who wants to do classification, but it didn't make a big difference. It was very, very similar. ADHD was higher in drug-dependent than in alcohol-dependent patients. Prevalence of ADHD was higher in inpatients than in outpatients, and this is the main prevalence. An important finding in this first study was that there was also a lot of psychiatric comorbidity in addition to the comorbidity of substance use disorder and ADHD. Any comorbidity in the patients with ADHD comorbidity was 75%. And you can see antisocial in 52%, borderline personality in 35%. Major depressive disorders, 40%, and mania, 15%. And you see the odds ratios, they're quite dramatic, and so there is a lot of multimorbidity in this population. We also looked at early problems, and there's a lot to say, but given the time, I'm just only mentioning the ones in yellow. Only 24 of the 196 patients, there's only 12% of patients with such substance use disorder and ADHD was diagnosed as ADHD before the study. Only 12%. And only 4% of these patients ever received ADHD medication. So you see it's a highly prevalent but highly undertreated population. It's not only psychiatric problems that they have, these comorbid patients. They also have a lot of risk behaviors. And as you know, ADHD patients in general are at an increased risk to die prematurely. This is what we also see. If you look at illicit drug use starting before age 15, it was much higher in the substance use disorder patients than those without ADHD, odds ratio of 1.75. Head injury with loss of consciousness more than 15 minutes, 37%, a third of them. Promiscuity, much higher. Driving under the influence, a little higher. It happens quite a lot. It's quite shocking to see that. License loss, a lot higher. So it's a dangerous life that people live in with a lot of risks. In addition to this study, we also extended the study with a site in South Africa and a site in Puerto Rico. And we also looked at tobacco. This is, I think, just one of the findings of this second study. There is still a big issue whether ADHD is associated and maybe causing substance use disorder, or whether it's antisocial behavior and oppositional defiant disorder behavior, conduct disorder and opposition defiant, that actually is the driving force between this relationship between ADHD and substance use disorder. And actually what we saw in this study, but you have to realize this was a cross-sectional study, that only 19% of the association between ADHD and the onset of substance use was mediated by conduct disorder and ODD, which means that ADHD is really an independent risk factor for the development of substance use disorder in children with ADHD. So we also, as a consortium, we started to think about what should we bring to the world, and the idea became that we should write consensus statements, and this is one of these consensus statements, and Cleo is, after my talk, is going to talk a little bit about how we came to these consensus statements. This is the one for adult patients, but we also did one for adolescents. This is, I'm just mentioning some of the main statements in order that we can test them in our next study. The treatment recommendations for patients with substance use disorder and ADHD were that you should have adequate and, if possible, integrated treatment of both the substance use disorder and ADHD. And that you should combine psychotherapy with pharmacotherapy in all cases possible. Also, we concluded that stimulant treatment or atomoxetine for ADHD should be considered, even giving higher dosages than the standard doses. And of course, if you do that, you should take care that there's careful clinical management to prevent abuse and diversion of these stimulants if you prescribe stimulants. So these were some of the recommendations, and then we started to say, okay, but what happens with recommendation? What is the current situation in the different countries that are part of our ICASA network? And so we decided to do a naturalistic cohort study with the following, and this is the study design that was presented 2 years ago in BMC Psychiatry. And the aims of that study were to describe treatment modalities received by SUD plus ADHD patients. what kind of treatment do they get in current available treatment facilities? To describe the differences in outcome from the different treatment modalities, to identify predictors for retention in treatment and prediction of reduction of ADHD symptoms and substance use, and to derive hypotheses for further randomized controlled trials. So this was the design of this naturalistic study, a naturalistic prospective study. We had a population of 578 substance use disorder patients with a clinical diagnosis of comorbid adult ADHD. So we started in centers because there were centers that were related to the ICASA members where we thought that they would have a treatment staff that could identify ADHD. So these were patients with substance use disorder and a clinical diagnosis of adult ADHD. Recruitment was in 9 countries and with different numbers in different countries. Assessments were at baseline, 4 weeks follow-up, 3 months and 9 months follow-up after starting treatment. Outcomes were treatment retention, substance use, ADHD symptoms measured with the ASRS, and improvement in social functioning. We had all kinds of predictors for these treatment outcomes, but of course, most importantly, type of treatment. For example, whether patients were or were not treated with stimulants. And we looked at all kinds of effect modifiers such as self-efficacy, anger and aggression, punishment and reward sensitivity, but this is probably not going to be presented today. So what were our primary findings, preliminary and most important findings? So we had 47% inpatients and 52% outpatients. Most common substance uses were alcohol, stimulants, and cannabis. And from the percentage, you know that most of them had actually more than one, and sometimes more than 2 or 3 substance use disorders. 87% had tobacco use. And as you know, tobacco use is probably the most important substance use that we know if you want to think about health issues. 71% had received substance use treatment before, but only and 41% had never received any ADHD treatment. And 61% had at least one additional comorbid psychiatric disorder, which is not a surprise if you saw the numbers that I presented before. This is, we're not going to look too long at it, but this is where you see at the top level, you see the countries, Belgium, Spain, Germany, Hungary, the Netherlands, France, Sweden, Switzerland, and the US. You see the substance use disorder on the vertical and the percentage of patients that fell in that. And you see there was a big range. For example, if you look at opioid use disorder patients, it was 18% of the total population, of the study population, but it was only 2% in the Belgian sample, or even now 0% in the French sample, and 61% in the USA sample. So you see it's quite diverse, the kind of settings and treatment sites that we included. Let's see what kind of treatments were provided. This is first the substance use treatments that were provided at baseline and or the first 4 weeks of being in treatment. And this is basically the pharmacotherapy for all substance use disorder. And you see, of all the patients that we had in the study, only 224, which is less than 40%, had any pharmacotherapy for their substance use disorder, varying between 6%, 7% for tobacco use disorder. Come on, this is quite shocking, isn't this? We are in substance use disorder, and 80+% has a tobacco use disorder. Tobacco use is a primary reason for illness and death. And 7% is treated for tobacco use disorder. But you see there's 40% treated for opiate use disorder. Now that is quite interesting, but the more interesting thing is when you look at the intersite variation. And if you look at any pharmacotherapy, you see it's 25% in Switzerland and 91% in Spain. Or if you look at tobacco use disorder, you don't see it anywhere in the addiction treatment centers in Sweden, France, and Germany, and it's 29% in the US. So you can do it also in these settings, but it's not done in a lot of countries. So interesting information that is large intersite variation if it comes to the treatment of the substance use disorder. Now looking at the ADHD treatments at baseline and the first 4 weeks of the treatment after coming to the treatment. Pharmacotherapy for ADHD was available or was received by these patients in 54%. I actually thought it wasn't so bad. But we say that it should be actually combined pharmacotherapy and psychotherapy. That was only 25%. And if you think that actually in most cases combined stimulant treatment and psychotherapy would be the preferred option, then it's only 17%. So you see, it's not so great. And again, large site variations. If you think about stimulant treatment, if you think about treatment at all, it's 32% in Sweden as the lowest, and 90% in the USA. But if you then start to look at stimulant treatment, then the US is suddenly the lowest with 21%. So they do treat the people in the USA, they are treated with pharmacotherapy for their ADHD, but they almost never get stimulants. They get atomoxetine or one of the other treatments. So again, big intersite variations, and that's maybe the most important message that we should have, that if we don't do anything, there is big intersite, inter-country variation, and that's something that we actually shouldn't have if we want to do evidence-based medicine also for this group of patients. Now, of course, you want also to see predictors of certain treatments. So this is the predictors for ADHD treatments and mainly the different types of treatment. Any treatment of ADHD, the big predictors were the severity of the ADHD. So the ASRS had a positive prediction value for getting any ADHD treatment. And if you had higher quality of life, you had a lower probability that you get treatment for your ADHD, probably representing also something of the severity of the ADHD. The predictors for stimulant treatment was very interesting. It was basically only patients who came in and were completely abstinent, they got stimulant treatment for their ADHD with an odds ratio of 1.6. So that's also a very interesting discussion. Should people be completely abstinent of drugs before you start any stimulant treatment for their ADHD? Interesting debate. This is how long they went on with the treatments. And as you can see, the sub-treatment for the addiction, it started 39% and it went down to 24%. Maybe because it was effective, maybe because they dropped out. We don't know. The ADHD pharmacotherapy and stimulant therapy, actually, if they started it, it was continued and it was quite stable. That's an interesting finding. People were actually seemed to be compliant and they didn't drop out. You see stable levels of these treatments. There were also other mental disorders, and the pharmacotherapy there was started with 48% and it went down again, probably because these treatments were effective and were discontinued. What was the relationship between treatment and treatment outcome? That is probably what most doctors would like to know the most. And if we look at retention, and there has been one study before, it was a retrospective study showing that any treatment, any medical treatment of ADHD in this comorbid group was leading to much higher retention. That's nice, but it's also nice if you see an improvement of outcomes. But at least if you look at retention, we see that stimulant treatment is an important predictor of treatment retention in this population. And also comorbid, the treatment of comorbid disorders, pharmacological treatment of comorbid disorders, they were actually the most important predictors of treatment retention. Employment was an important, if you're employed, then you just have much better chance that you stay in treatment. Predictors of a 30% or more reduction in the ASRS score, so in ADHD severity, at 3 months follow-up. Again, the most significant predictor was their stimulant treatment. with an odds ratio of almost 3. So stimulant treatment leads to a significant reduction of ASRS symptoms. Here we have a finding that we don't know to explain. If people had a diagnosis of sedative use disorder, benzodiazepine disorder, they had a much lower chance to have improvement of their ADHD symptoms. We cannot really explain it. If you have explanations to offer, please tell me. And this, it's a horrible slide, but it's preliminary dating. This is probably what you would like to know. Having more heavy drinking days in the subgroup with an alcohol use disorder. Again, what you see, there were less heavy drinking days at 3 months follow-up in patients who had psychological or stimulant treatment of the ADHD. So again, stimulant treatment of ADHD comes up also not only as a predictor of retention or only as a predictor of ADHD improvement, but also as a reduction of alcohol use, heavy drinking days in this subgroup. Yeah. So, summary and conclusion of the INCA studies. The treatment recommendations in the consensus statement are very often neglected. This was a painful conclusion for us, of course. Only 93% with pharmacotherapy of the substance use disorder, only 54% pharmacotherapy for the ADHD, and only 41% with stimulant therapy. And as I told you, the US does very good with pharmacotherapy, at least that side that we had, but they don't want to prescribe stimulants, and there's a big debate. Also, what was shocking for us, that's only 20% get pharmacotherapy in combination with psychotherapy. And the most important, the large side variations. Stimulant treatment, and that is also a very important finding, has positive effect on ADHD symptoms and on alcohol outcomes. And then, of course, there's study limitation, because this was a prospective study, but it was a naturalistic study. There was no randomized controlled trial. So there can be all kinds of biases and confounding. We controlled for the ones that we had. And it was in identified comorbid patients, so probably the ones with quite severe ADHD that could be recognized and diagnosed by the clinical staff. There was some dropout, and of course, we didn't analyze the data for the drug use in this population, which is still underway. So we have some future activities. We're planning to do studies in adolescents in the case that maybe we can prevent the development of substance use disorder in children with ADHD. Now I have 9 seconds left. And if you want to collaborate there, just make a picture of the QR code and you can contact us. Summary and conclusion of the talk. ICASA is a stable and productive network, as I tried to show you. And it's a network of research practitioners. And if you feel that you belong to that group, contact us if you want to collaborate. ADHD is a very frequent comorbid disorder in treatment-seeking patients with substance use disorders. The ASRS is a useful, but definitely not a perfect screener. They show high comorbidity with other mental disorders. Only a small fraction of comorbid ADHD is recognized and treated before they came to our study. And treatment recommendations were variably followed with low stimulant prescription. Stimulant prescription, most important predictor, was the positive predictor of good outcomes. And finally, I'm not going to repeat that, it seems that we really have to start treat patients with ADHD in order to prevent the development of substance use disorder. And if they develop a substance use disorder, we have to start recognize them better and to treat them with medication and psychotherapy. Thank you very much.
So thank you for that absolutely fantastic talk. Wim is working as a bit of a double act today, so I'm now inviting up Cleo Crunelle, who is a professor of psychiatry at the University of Brussels, VUP, and at the University Hospital Brussels, and also a board member of the International Collaboration on ADHD and substance abuse. And to my absolute amazement, Cleo has 2 PhDs, which just shows the quality of what we're about to hear. So, Cleo, the floor is yours.
Thank you very much. Thank you very much. It's not very easy to come right behind Wim, but I will try to guide you a little bit today through the process of how we develop these international consensus statements. And it goes about the adult one, also the adolescent one. There has been a lot of activities on ICASA, but this has been also a very important one. So let me guide you through it a little bit. Substance use and ADHD, they often co-occur. We know that by now. I can see it on the amazing amount of people in this session that you've probably encountered also a lot of patients with substance use disorders where you suspect that some adult ADHD as well. And often these are the patients that come to us with an earlier onset of substance use, with more severe use, with more relapse, more chronic substance use, more polysubstance use. But we also know that having substance use disorder actually influences how ADHD symptoms present and persist. Symptoms of hyperactivity, impulsivity, inattentiveness, but also symptoms of affectability and irritability. And what has been known as well is that having substance use disorder influences the treatment of ADHD and also the treatment response to ADHD pharmacotherapy. For once, of course, some are really reluctant to prescribe ADHD medication to people with substance use disorder for fear of aggravating substance use. And I think that's why many countries prefer to use non-stimulants as well. But we also know from neurobiological studies that the brain dopamine systems is inherently different between patients with ADHD and substance use dependence compared to patients with ADHD without substance use dependence. So there is also a very good reason that treatment should not be exactly the same, but that we should try to treat. So if we look at the earlier studies, the earlier randomized controlled trials that were performed in adults with ADHD and substance use dependence, we see that if you treat ADHD in this patient population, you have a mild, moderate reduction of ADHD symptoms and little to no effect on substance use disorders. There are some exceptions. You see 2 studies with little green arrows. I don't know if I have a pointer. I do. No, doesn't work. It's the study of Maya Constanius in 2014, which used higher than regular doses of methylphenidate, I think up to 180 milligrams a day if tolerated. And she saw effects on both ADHD symptom reduction as well as on substance use. And also Francis Levin in the States performed a study in, I think, cocaine use dependent patients with adult ADHD, providing them with either placebo, mixed amphetamine salts in 2 doses, 60 and 80 milligrams a day, and also in the higher doses she saw the same results as Maya Constanius saw in Sweden. If you treat with psychostimulants at enough and higher doses, you might get a very, very good response on symptom reduction. I won't go into this too much. This is what Wim told us already. Some 10 years ago, there was a meta-analysis showing about 23% of treatment-seeking substance use disorder patients having underlying ADHD, and this has well been reproduced not only by the ICASA network, but much broader. But in the ICASA network, we had a big ES study on about 3,500 patients with substance use disorder being screened for ADHD, and about 2,200 in total, if you count both studies together, that actually been diagnosed extensively using structured clinical interviews for ADHD. And that didn't really matter inpatient, outpatient, age, a little bit more in substance use disorder and alcohol use disorder, but also it didn't really matter age, effect, or whether they were diagnosed on DSM-4 or 5. So it's a rather stable prevalence that has been replicated since. So the ICASA network was well aware of the population prevalence, of the many difficulties in the treatment, and we had some questions we tried to address. Some questions on, can we screen for ADHD in patients with substance use dependence, and what should we use to do that? some difficulties, some concerns on diagnosing patients with ADHD in populations with substance use disorder, some problems with over-representation of symptom under diagnosis, but also who can make the diagnosis, when you should make the diagnosis. Should you wait for a long period of stabilization, or can you go on already with starting some observations, some screeners? And mainly, one of the main reasons for the consensus statement was also the many studies on the treatment of ADHD and substance use disorder. Should we use pharmacotherapy, and which would you prefer to use? Taking into account, of course, safety, possibility for diversion, treatment retention, and also the non-pharmacological options. And so it all started in 2015 with first a very broad literature search that guided us through a lot of guidelines, not much to find through PubMed and all the older known, very well known sources for literature searches, which ended up that when searching on the literature for ADHD and substance use, there were about some more than 200 papers, but very general papers to be found on ADHD and substance use. Also some randomized control trials. That led us to a lot of consensus meetings with the ICASA statement, with the ICASA network. We had network meetings in Stockholm, in Brussels, in Budapest. You see some of the faces, and probably you will recognize some. Probably some are also here or wandering around here at Lisbon Addictions. But during these consensus meetings, we discussed the statements that we obtained through the literature or where we had questions about. And this was really network meetings with practitioners that are actually involved day in and day out with patients with substance use disorders and adult ADHD. And in 2018, this led to the actual publication of the first consensus statement for adults with ADHD and substance use disorder on how to screen, how to diagnose, and how to treat this patient population. And this is freely available, so you can look over the statements if you want to. Wim showed already some and discussed already some of the more important ones. And I think the main statements here, without wanting to repeat Wim too much, is that there are some screening tools that are very useful to screen for ADHD and perform actually very well. And one of those is, for example, the ASRS, the Adult Self-Report Scale for ADHD in adults. But also that you can start the diagnostic process soon, and soon means at least when there's no serious withdrawal symptoms or no serious intoxication. But that it's not always necessary to wait for a very large time of full abstinence, because usually that's not even feasible. You can start really early with observation, with screening, with clinical history taking. But also that it's very important to, throughout your diagnostic process, to verify it with follow-up, to use standardized instruments, and regarding treatment, to integrate ADHD treatment with substance use disorder treatment, if that's possible, and if that's not possible, to at least treat both disorders together in parallel. Pharmacotherapy was, as I said earlier, this is a very reluctant something to prescribe stimulants to patients with substance use. At least it was when we started with the first consensus statement. We know that there's a risk of misuse and diversion, although it's often less important than we think. We see it especially in adults, in adolescents, and young adults, and especially with immediate release preparations. That's why one of the statements in the consensus statement is to use long-acting stimulant formulations like orosmetylphenidate, Concerta, or lisdexamfetamine. But if you look at adverse events, they're very comparable between patients with ADHD with and without substance use. And what is very important is that you don't aggravate or precipitate substance use. On the time of the development of this consensus statement, the literature was not yet as broad as it is now. I will come into it later. But by the first statement, it was one of the most important statements that in patients with substance use, treatment of ADHD can be useful to reduce ADHD symptoms and without worsening substance use, and so it should not be avoided. In adolescence, it was a bit the same. We started asking questions, we started looking at the literature, and there was even less available than on adults with ADHD and substance use. Although we know that having ADHD is one of the risk factors of developing substance use later in life, the literature is very, very scarce. So in 2018, a task force of the ICASA with a lot of child and adolescent psychiatrists, child and adolescent psychologists, addiction physicians, scientists, health practitioner, epidemiologist, very multidisciplinary, started writing up, according to the literature, on the adolescent statements of ADHD and substance use, and we did that through a modified Delphi procedure, meaning that we invited a lot of experts, 62, of which a very broad amount participated, 55 participated. They received the statements, they thought together with us on changes, on agreements, and they were sent through for a couple of rounds, and after 3 rounds, all statements were, had a consensus, all but one. I will come on it later. So there are 37 statements on treatment, diagnosis, and screening of adolescents with ADHD and substance use. These are very general statements as well that actually follow the adult consensus statements on quite a lot of topics, but there are also some very fine changes and very fine important details like involving parents and other confidence in treatment and how to discuss about substance use or ADHD symptom in this specific adolescent population. And by then the literature had evolved as well, and we knew much more on the risk of developing substance use. And it was very clear that childhood ADHD was a risk factor for developing substance use, but also that if you treat children, adolescents with ADHD from a young enough age and with adequate doses, that you might even prevent the occurrence of substance use later in life. So that makes it very important towards the consensus statements as well. Also for the adolescents, a combination of psychosocial and pharmacological treatment is one of the things that is hampered on. But we also do address long-acting psychostimulants in adolescents as a first-line treatment for ADHD, also in adolescents with substance use disorders. Of course, if there's cardiac preconditions, don't forget to do an ECG. And of course, for children, it's very important to monitor growth and weight. The second line, we have the other options, atomoxetine, guanfacine, bupropion. If stimulants are not tolerated well, if there is misuse or diversion, and very important to discuss these preconditions and monitoring. But it is very important to detect ADHD and substance use early enough and actually treat them, paying attention to the overlap during the diagnostic process as well. There was one statement we didn't all agree on. We did not do a 4th consensus round. It was also a very broad statement. It was the following. Before starting stimulant pharmacotherapy in adolescents with ADHD and SUD, it's important that the adolescents are abstinent or have reduced, stabilized their substance use. And if this is not the case, the clinician should consider non-stimulant pharmacotherapy, such as atomoxetine, guanfacine, bupropion. So the disagreement was on a lot of several parts of the statement. Some did not agree that full abstinence had to be reached before treatment could be initiated because it had repercussions on substance use and treatment for substance use. Others didn't agree at all to prescribe stimulants to adolescents with stimulant use disorders or with other use disorders, and other ones didn't agree at all with using bupropion as a non-stimulant treatment within ADHD in this patient population, especially adolescents. So I think that I would also tell you to actually go look up this paper where you can find all these statements as well as the whole procedure going behind it. It was a very elaborate piece of work as well as the adult ones, and it's also freely available. And so now, 2024, time passes very quickly. We have decided on the ICASA last year to actually update the consensus statement for adults. We are 6 years after the first consensus statement, so this seems like a very good time to see what happened in the literature since, if what we stated then is still available, is still within what the literature says. And so this is in progress. It's just a little heads up, which means that please don't photograph any of the slides or wait a little bit until the actual consensus, hopefully 2025, will be published and further developed. But for now, we started with a literature search, and what is already amazing is that while the last search rendered about 200 papers in a time span of like 25 years, in the last 5.5 years, there's already more than 100 new papers on ADHD and substance use disorders in adult populations. We already had a consensus meeting in Gibraltar in July with Scholte Metrovic, who organized it. And we have another one planned, and there will probably be another one planned as well after that. So this is really work in progress. And the beautiful thing to see already from the literature is that the main statements of the first consensus statement, they are still very much true, in the fact that even what was said through clinical expert opinions is actually now can be found back in the literature. So we have much more proof for the statements as well, which is a very nice thing to do if you start with statements where part of it is based on expert opinions. What we also clearly see from the literature is the persistence into adulthood of ADHD symptoms in those with substance use disorder. We have always known that in children with ADHD, about 1 in 2 will persist with ADHD symptoms, having ADHD throughout adulthood. In patients that also have substance use disorder, it's more like 80%. A lot of studies are on the prevalence, a lot of prevalence replication studies who also more or less show the same results, and even a large meta-analysis in about 13,000 patients showing almost exactly the same number, an ADHD prevalence of 21% in adults with substance use dependence. So I think we are very clear that 1 in 4, 1 in 5 patients with substance use disorder has an underlying ADHD that should be treated. Regarding the screening, there is more evidence that argue against the fact that screeners might overrepresent ADHD, and there are a lot of discussions through what cutoff to use, if we should use the same one as we do in ADHD without substance use, or if we should lower or high the cutoff a little bit. But there is more and more evidence that screening of ADHD is very reliable in patients with comorbid substance use. On the diagnosis, there are some more studies that go into a bit deeper on that emotion dysregulation, that affectability, and the differential diagnosis with bipolar personality disorder. And there is also even some studies on the paradoxical calming effect of cocaine, something we see often when we have patients into our consultation with substance use that say, yeah, my head gets so quiet, it's wonderful. What is also pretty interesting is there were a lot of randomized controlled trials that have been presented in the earlier statement, and there are little to no new ones. So there are registry studies now that look retrospectively on what has changed, and if we look at the development of the last consensus statement, we see that since 2015, ADHD pharmacotherapy prescriptions have increased marginally, but to date, it's still mainly the patients with ADHD and substance use disorders, more than those without substance use disorders, that remain pharmacologically untreated for their ADHD. And the whole discussion on higher than normal doses of psychostimulants still remains, but there is more studies that, toxicological studies that show that in patients with substance use disorders, compared to those without, that there is much more variation in plasma levels of methylphenidate. So that might go towards looking more individually if higher doses are required, but also some neuropsychological findings that if you give regular dose methylphenidate in this patient population, that you actually see little normalization of processing speed. And that might also go towards maybe some higher dosages can be really useful. And one of the last things I want to talk about are the fact that there's a lot of new studies on non-pharmacological interventions of ADHD and substance use. There is an integrated cognitive behavioral therapy approach with some wonderful findings, but also some studies on dialectic behavioral therapy, on brief motivational interviewings to reduce drinking in patients with ADHD, and also on neurostimulation like electrical stimulation or magnetic transcranial stimulation. And regarding treatment retention, we know that having substance use disorder, that there's more relapse in patients with ADHD. And the dropout rate is ×9, so that is really huge. But, as Wim said also, if you treat with ADHD pharmacotherapy, it would be associated with a better long-term retention in treatment for substance use. And we see that in patients receiving ADHD pharmacotherapy compared to those not receiving ADHD pharmacotherapy. So this was a little heads up for the new consensus statement, but keep in mind this is very preliminary. It still needs to be written down, still needs to be discussed elaborately. And hopefully next year I can present to you the new guidelines. And thank you very much for your attention.
So thank you, Cleo. Hold on to your ADHD questions. We're still going to stay with developmental disorders, but we're now going to move on and talk about autistic spectrum disorders. And I'm going to welcome a colleague of mine, Professor Julia Sinclair, who is a professor of addiction biology at the University of Southampton, an honorary consultant in alcohol liaison at the University Hospital Southampton, and was a previous national specialty advisor for alcohol to NHS England, as well as being an SSA trustee. So welcome, Julia.
Thank you, Owen, and thank you to the SSA for putting on this session, and particularly to Sarah Welsh for organising it, and also to the SSA for funding this particular project, which I want to talk about at a very different level from the great work that we've seen with ICASA. So this is my declaration of interest, which is pretty minimal in terms of anything that might conflict with this. And I also, well, actually move on to the next one. Sorry, just also trying to work out how to use this. What I want to start with, though, is just kind of thinking about two things that two concepts that you'll be familiar with, but I think are really important in terms of the conceptualization of this talk. And the first of that is about the fact that we do often work in silos, and and then our journals publish in silos, and it does what it says on the tin here. And therefore, I think we kind of often get really quite embedded within our own sort of area and with our own specialty, and either then apply that to other things or don't think about it at all. So that's one of the great things about Lisbon addiction, is that we all kind of get to mix up a bit and hopefully be challenged in terms of some of those kind of concepts. The other thing in regard to stigma, and although this picture on the right is about ADHD, I've put it here because it's work from some of our medical students, and we have a program with them where we get them to kind of, work through some things about things that might be kind of stigmatizing. And whilst we're all kind of familiar with stigma, I think when you're trying to look at things at the boundaries, at the intersection of kind of different conditions, both of which are stigmatized, actually, I think it's really a very relevant concept that we are thinking about. So, why are these things important? As I've said, I think researchers and clinicians, we do work in silos, and some of that intersectionality gets lost. And most importantly, therefore, the impact on people of stigma, discrimination, reduces their ability to access appropriate services, and I'd say also the research and policy to enable that. And we're living in a time of huge kind of economic challenges, and as services shrink and perhaps protect their particular area, there is much more opportunity for people to fall through the chasm if you don't fit neatly into people's kind of service provision, which we've heard a lot about in the conference so far. So I think this is important, and we started this really because we weren't sure what the overlap was perhaps between substance use, alcohol use, behavioral addictions in people with autism, and also aware of the fact that actually some of the constructs around use of the internet, gaming, and behavioral addictions were really not well defined when we were thinking about a wide concept of autism and some of the features that people, autistic people might kind of show. So in terms of the background, when we were looking at this, and this was a UK-focused study, it's where it started, but actually we involved an international group of people to conduct this. But, you know, there was about 700,000 people in the UK who were on the autistic spectrum, and a couple of systematic reviews, recent ones, would suggest that up to 36% of autistic people kind of may have a substance use disorder, but really the evidence on that is not great. There was another recent systematic review when we started this project which looked at kind of comorbidities in autistic people, and actually, you know, there they are for you to see, but there was very little on substance use disorder. So the project that I'm going to be talking about was a priority setting partnership, and I'm going to kind of give a bit of explanation about that. And so we had three main aims. The first was to have a priority setting partnership, and absolutely essential to that to include clinicians, researchers, and both people with lived and living experience at the intersection of those areas. And I think that was a really important thing when we were thinking about bringing this together. The second was therefore, you know, the aim of this was to reach consensus on a final list, so we nailed it. We said, okay, top 10. Random figure, 2 figures. So top 10 of jointly agreed research, policy, and clinical priorities, to publicize them and to make sure, you know, that the uncertainties are recorded so that we have a baseline for people to take that work from. And then the final thing was to produce a toolkit based on the completion of this project, such that other people working in the field of addictions who are planning to do priority setting partnerships could actually access it, because there are other priority setting partnership around, but we thought that perhaps they didn't necessarily help that much within the addictions field. And a final thing was that at an early stakeholder meeting, we agreed to use the first person language, so we talk about autistic people, and we're kind of very aware of the fact that there is no universally agreed kind of statement on that, but there are differences of opinion, so I don't want to offend anybody who chooses not to use the first person language, but this was the one that, in conjunction with our stakeholders, we agreed to use for this project. So what is a priority setting partnership? We've published on this, and I'd encourage you to look at that. I think in terms of our authorship here, this is a mixture of people both with lived experience, experts in the different ranges that were there. And I think a really important part of this, and it was something that Bronwyn mentioned in her keynote yesterday, who was also part of this group, is that we come to these priority setting partnerships as experts, but we also bring our mixed lived experience with it, some of which might be declared and some of which is undeclared. And I think it's a really important thing that we need to note, that we, you know, that, as I said, we all come as human beings to these things. So the aim was to bring together clinicians, researchers, and policymakers, as I've already said. And in terms of the process of a PSP, the aim is to make it kind of meaningful engagement and really a transparent process, which is what we wanted to look for. And a particular aim for this was to make people from different silos talk to each other, with all the challenges that that brought. And there were quite a few challenges, and it was an interesting part of the process working that through, and we can talk about that. We wanted this balanced inclusion of lived experience, researcher, policy, and clinical interests, and we really didn't want to exclude any groups or organizations other than those who had really a significant kind of competing or commercial interest in the field. And we've kept throughout an audit trail of all the submitted uncertainties right the way through to our full priority list. So in terms of the process, we started off by identifying the key stakeholders for our steering group, which is an international group I'll show you at the moment. We then did a structured scoping review of the literature to try and identify gaps. And I think when you're doing a priority setting partnership, your literature reviews are quite different in some ways, because instead of synthesizing what's there, you're trying to actually look for the holes of what is not there. So I think that's an important thing just to kind of flag up at this point. And then, as you can see, we went through a range of things which I will show you as we progress. So these are our steering committee with, as I said, a balanced number. We had 2 people with lived experience of both that intersection. So Chelsea Flood, I'll show in a moment, is a writer, and Chris Torrens is an autistic person, self-defined autistic person, who also actually works as a practitioner within a substance use service. So it was really great to get that kind of experience. He also works with quite a few of the large autism charities in the UK. We had public organisation representative, expert in autism, which my colleague from NHS England, who is the specialty advisor for autism, had experts in terms of problematic alcohol use, substance use, and behavioural addictions. And I just want to flag up Chelsea's work. So as part of going out and asking people to be involved, Chelsea actually kind of presented herself to us and said, you know, I'm a person who as she put here, is that I got sober, I became painfully aware of my people-pleasing habit, and I'm working to destroy it. And actually, it was really only after she realized that she was, had been a person with autism all her life, that actually she realized she could understand her alcohol dependence and deal with it. So the other thing that I just need to kind of clarify here is that one of the challenges in both talking about this and undertaking this piece of work is that we're dealing with kind of concepts that exist in a huge spectrum. So if we think about autism, and as I said, we're talking about autistic people, we agreed to have it as a self-defined because we didn't want to exclude anybody. But actually, when you think about that, that includes groups of people who remain non-verbal, so people who are unable to live independent lives, right the way through to people who have some autistic traits which actually make them phenomenally successful in their chosen field. Then obviously when we're thinking about alcohol use disorder and substance use, we chose to think about problematic alcohol use just because of the fact that it's such a societally available drug, and substance use, we included all forms of substance use. And when it came to behavioral addictions, we focused on gambling because that is the one for which actually we have a diagnostic criteria now in DSM-5, but also that is where most of the evidence is there. So as I said, these things are very much on a spectrum. And what we were looking for, particularly for this particular project, we made the active decision to limit the focus of the intersectionality between autistic people with alcohol, substance use, or behavioral addictions, partly because we had a huge amount to do anyway, but also partly because we wanted that focus there. And it's not in any way to kind of suggest that those other areas of intersectionality are not kind of really important. So we undertook literature reviews, first of all on autism and substance use, autism and problematic alcohol use, and autism and gambling, as I said, to try and really define those gaps as part of then involving stakeholders if there were things that were already kind of clear. So I'm going to talk a little bit about the autism and gambling one, and then towards the end, because it was a later part of this project, was a second project afterwards about our alcohol one. And quite early on, after we'd done an initial scope of the literature, we made the decision to leave the substance use disorder one. So if there's anybody who's keen to take that forward, come and talk to me afterwards. And so we, partly because of the evidence that was there, but also essentially we had to focus our resource. So in terms of our autism and gambling systematic review, this was very much focused on neurocognitive tests that had already been done. And as hopefully you can see there, we started off with the kind of usual way of screening these things, and we ended up with 9 studies. And in terms of those 9 studies, it was the first systematic review to examine the overlap between ASD, autistic spectrum disorder, and gambling. And I think just the couple of things that I want to draw to your attention on this slide is that actually only 4 of the studies, the ones that are highlighted in blue, if you can see those, so that is the Wu, Vela, and the Hosnova. And actually of those are the only ones for which actually there was more than 26 participants per group, which is the minimum that you would need to be able to show a difference between a case and a control. So all the rest of these are underpowered. They were essentially, the tasks that we used were either the Iowa or the Cambridge gambling task. There were a couple of non-validated tasks used, and the recruitment was often not specified in either group. So you had this kind of, it was a starter. We put a marker in the sand, but to be honest, I wouldn't think that we've done much more than that at the moment. So I think from the purpose of this project, what it showed us was that actually the evidence that is there at the moment hasn't answered any of the questions we might want to know about this. So what it did, and I've got the little slide here about looking under the lamppost, is that people started where they were. So, you know, neurocognitive researchers had their gambling task, they tried it in people and reflected upon it. But it didn't really put any limitations on what we wanted for our partnership. And so I was going to take you through the next few slides around what a partnership, a priority-setting partnership, actually does. And then I realized we actually have this beautiful video, which I'm therefore going to play you, which I think was part of encouraging people to come forward. And this was what we did. It does have music on it, which I tested just before we came in here and was told that it would work beautifully, which of course it isn't. But that's okay. So in terms of this, as you can see, this was one of the things about engaging our stakeholders. Our research, I stopped because I thought there might be music, but I think that was just a hallucination on my part. Okay, so what we were doing, oh, it's there. There we go. It's just nice mood music, we'll be fine. What you can see is it's trying to do is it's telling people who we are. We're asking people, are you kind of, you know, is this something that you would be interested in taking part in? Have you used alcohol or substances that have caused problems in your life? Or do you have any behavioral addictions such as gambling? Or are you a carer or friend of a person, an autistic individual who has behavioral addictions or problematic alcohol or substance use? Similarly, we wanted to have a full range of clinicians, researchers, professionals, or volunteers. And really an encouragement that we wanted people to engage with us about the things that were important to them. And this, I think, is the key thing that perhaps is a priority-setting partnership rather than a consensus statement, which is we're trying to actually bring in that sort of breadth of the field at the moment. So this is then the method. We want people to take part in our survey, which we'd constructed. We want people to let us know what their questions were, and we guided them through some of the specifics. We were then going to gather them together, sort them into groups, send them to our stakeholders. So that was this broad range of people who'd opted in or international experts that we had contacted. And then we were going to go through this Adelphi process, which Cleo's already talked about, where you rate those questions and have a sense of what the impact of them might be. Bring then those stakeholders together, so this is the Delphi process, in order to define those top 10 questions or priorities. And then our plan at the end of that is to let clinicians, scientists, and autistic people, policymakers, know the final list and to shape the future together. So part of this dissemination is what we are doing here. So this was made by our researcher on the project. She said to me, you know, I can do us a little video. And I said, that would be lovely. And literally 24 hours later, she came up with that. She has great skills. And so in terms of that, moving on to the next thing, we then sent out the survey to 78 participants took part in it. It was, you know, spread across various social media on the SSA website, places that people would be looking. 610 questions got asked, and we divided them into about those 3 areas. We then had some additional workshops, both online and also face-to-face with kind of groups with an interest in the area. And in total, there were 340 unique questions recorded. And so by a kind of qualitative thematic analysis, we managed to reduce those to 38 very broad questions, of which 12 were policy, 11 were research, and 15 were about clinical practice. As I said, we then went back out to recruit our Delphi members. So partly that was from our steering group. Anyone who was on our steering group could take part in the Delphi process. Anybody who'd actually taken part in these stakeholder meetings who wished to be part of the longer process were very welcome to join us. And then we also went back out and sought further international expertise. And so as part of that, we had an online meeting. We had 2, because we had colleagues from Australia, so we needed to get the timeline kind of doable for everybody. We presented the evidence of the systematic reviews and the questions that we'd had to clarify the uncertainties and to make sure that everybody was sort of on message in terms of what we were trying to achieve here, which was a really important thing to kind of get everyone together. We had a discussion of any questions that there was concerns about, and then after that Delphi process, we then kind of went through the iterations online of the questions that came out. We had 2 iterations, which I'll show you now. So these 38 questions, we had 21 of our 22 Delphi members took part. Everybody individually rated it, gave comments, suggestions, and feedback. We then went away, brought those together, slightly altered what we had been asking people. We kept with our 38 questions. There weren't any additional ones. When we sent it back to people, part of the Delphi process is that you say, this is how the group rated it, this is how you rated it. Do you want to change your rating at all, and any reasons for change or for sticking where you are? And then after that, we had our kind of 15 kind of policy, practice, and research questions. And so for the final time, then we took out to people and said, okay, you've now got to nail your colors, which is you've got to rank these 1 to 10. Okay, so there was a total ranking. And of those, we had responses from 18 of our 22 panel members, and we came out with our top 10 priorities, 3 of which were policy, 3 research, and 4 were about practice, which are here for you to see in the paper. And the ones just to really focus on, which I think in relation to where we are here, one was about kind of mechanisms, the specific kind of triggers, risk factors, and facilitators of SABA, so substance, alcohol, and behavioral addictions in autistic people, and what steps could be taken to prevent these. I think that we were very keen about the idea of what training of professionals needed in different sectors to enable them to better support autistic people who have SABA. So in our workshop, our workforce theme this year, that is key. So that was our priority setting partnership. As I said, we convened it, we reached our consensus. I just want to show you another bit, which was our kind of toolkit about that. And the picture of Betul Aslan, who was our researcher on this, and I was really thrilled we were able to recruit her. She was a fairly newly arrived refugee, and she came wanting to do an observational kind of placement to reboot her psychology skills, and actually I told her just to apply for the job because her skill set was so great. And she was an absolute asset to the whole project. So she very much helped with this, and we now have this toolkit, and as you can see, underpinning that is all the processes that we went through. And just in the final couple of slides, I just want to talk about the next thing that's come out of this. When I put these slides on yesterday, up at the top, it was under review. I'm pleased to say, as of this morning, it's now been accepted by the British BJ Psych Open. And this was a young clinical psychologist who kind of approached us after the SABA project and said, what about the clinical populations of alcohol and autism? And he then took our systematic review that we'd started and has worked with us since then to to look at that. And just to show you the details of that is that there are 22 studies included, focusing on the clinical populations. So those were 5 studies in alcohol use disorder populations, 3 in autistic spectrum disorder populations, 1 in both, 3 in forensic populations, and then these kind of registries and cohort studies which are there. And from that, there was a total of 750 autistic participants from clinical settings, and obviously over almost 400,000 from these large population registers. So it's enabled us to start to kind of put a figure on this. So the pool prevalence of AUD in autistic spectrum disorder is about 1.6 and 16% in terms of the large population registers and clinical settings respectively. When we think about lifetime prevalence of alcohol use disorder in the global population, it's about 8.6. So it's probably kind of correct, that range that we have there in autistic people. And so that came from this 4 etiological kind of factors, and this will be my last kind of proper slide. So what I think Will has been able to do and do really nicely in this is start to kind of develop this concept map around how we think about what might be useful for practitioners. So we have the genetic pattern, the comorbidity, the gender and age as factors that might have an influence on autistic people developing alcohol use disorder. It also allowed us to think about some of those protective factors. So the fact that actually receiving a diagnosis of ASD prior to developing your alcohol use disorder and having current medication may actually help with that. Looking about actually the difference perhaps in this group about self-medication in terms of dealing with some of the sensory overload, but also the fact of how do you go out in society where people are kind of there and it's quite complex, and managing that in terms of self-medication. But what then that develops with us is these two kind of maintenance loops, one of which was about negative reinforcement, one of which was about negative reinforcement, so that relief from the sensory overload, and one of which was the positive reinforcement about actually getting more out of society. So I think this is a really helpful first step in terms of trying to think about the complexities of what we are trying to do here. So I'm just going to finish with saying that, autism, AUD, SUD, and potentially addictive behaviors, they're all on spectra. We need to think about the mechanisms of action and motivations may be very different in people with a wide range of autistic traits or disorder, and that we need to kind of engage stakeholders with all the challenges that brings in terms of trying to then improve things for people. So thank you very much indeed.
Okay, it's your turn. If you can come to the microphone with questions. Just while I'm giving you a moment to come up to the microphone, I'll take the chair's prerogative of asking my question. The question is about the prescription of stimulants to people with substance use disorders and the reluctance of many clinicians to do that. And I wondered whether, Wim or Cleo, you had some thoughts on how we might support clinicians to make this complicated clinical decision, but how we might help them to do that more easily.
I think that was also one of the reasons for this first consensus statement, to give some guidance, support, and some facts and not myths about the fact that you can treat with stimulants and that you won't aggravate substance use. So I think one of the big hopes of the consensus statement would be that people would be less reluctant to go for treatment of ADHD and mainly for stimulant treatment of ADHD. But we see indeed that the prescription increased since, but they increased mostly in patients without substance use disorders rather than those with also substance uses. I'm an ever optimist, so there are marginal increases as well. So I do think it has some impact, and I hope with the update of the consensus statement with much more research that it's indeed useful to use stimulants in those with ADHD and substance use disorders, that this might take away some of the reluctancy of the physicians, specialists, psychiatrists. Yeah.
Great. Wim, anything to add?
Yeah, maybe if you start to think about doctors not as technicians, but actually as uncertainty managers, because that's what they mainly are, then it's obvious that if you do nothing, you run no risk and nothing will happen. Not for the good and not for the bad. If you do use stimulants, sometimes it might go wrong, but in many more times it will help. So maybe something will happen. And so if you start to see yourself, and you're not always right, because you make mistakes or you make wrong uncertainty estimates, but that's what we are. And so I don't say that you have to use high doses. The only thing what the data tell you is that you might want to go in higher dosages with these patients if there is circumstances. And that's where you come in as an uncertainty manager.
Thank you. Let's come to the questions. Let's start with microphone 2. I think you were first.
Okay, thank you. I'm Andrzej Kupczyk from Medical University of Warsaw. First of all, thank you very much for the ADHD presentation, which I found very clinically relevant. I thought about the mysterious association that you talked about, Wim, so I thought that maybe the patients who use benzodiazepines, which you said that have worse outcomes in the treatment of ADHD, might have some comorbid anxiety disorder, so I would treat using benzodiazepines as a marker of comorbid anxiety disorder, which I think is a part of a broader problem, which I would like to ask you. that we sometimes overlook that there is also another comorbidity, that some of the patients with ADHD who use substances may use substances to treat like anxiety disorder or depressive disorder, and not only because of ADHD, but also because of this comorbidity. And then the situation is very complex. So my very specific question is what to do in the terms of like pharmacotherapy when I have a patient with comorbid ADHD, substance use disorder, and for example, anxiety disorder. So specific questions. I have a patient with alcohol use disorder, comorbid anxiety disorder, and ADHD, and I would like to give SSRI, I would like to give naltrexone, and I would like to give a stimulant. So what would you suggest, in which sequence, and would it be like useful to make also in the guidelines, which we don't talk about, like this additional comorbidity, because it's like, I think it's common with these people. So this is my specific question.
Nice, easy first question then.
If I can respond.
Yeah. As a clinician, I think it's practical, what we do in our clinic.
We indeed do see a lot of comorbidity, and we do treat that as well. And we do treat the anxiety with SSRIs as a first line first, and we do treat the depression, and we do treat the OCD, but the ADHD is still there, so you should still treat with stimulants. It becomes more complex, but for example, in patients with depression and ADHD, it's an option to go for bupropion first, and sometimes add a stimulant. And I must say that I also have patients with bipolar disorder and ADHD. It's not a diagnostic dilemma. It's rather certain that both are comorbidly there. And they have been treated for years with for example, lamotrigine or lithium, and they go relatively well, but they actually go better if you also treat their ADHD with stimulants. And they don't go worse. It can happen, but usually they go better.
But would you, in terms of SSRI, would you go first with SSRI or with stimulant, or both at the same time?
May I add to that?
Bupropion is, because when you have bupropion, it's easy, right? When I want to treat anxiety, right?
Yeah, no, but maybe the first thing is, if you see a patient with 5 disorders, let's think maybe he or she doesn't have 5 disorders. Maybe it's also an artifact by our classification system. So I think if you see 5 disorders, lean back and start talking to your patients and see to make something out of these 5 different disorders, and choose where, maybe not on a diagnostic, but on a dimensional level, where your primary treatment will go. Not ignoring all the other problems and not shouting to all the other psychiatrists that made the wrong diagnosis, but just start to say and discuss what is your best option, and try to agree with your patient what's your best option. And it could well be that you start with only ADHD treatment and see what happens before you do all the other things. But do it in close collaboration with your patient.
I start with SSRIs, because in some cases
I'm afraid we're going to have to stop. There are other people waiting for a take.
Thank you.
Over to microphone 1.
Thanks very much. Nikki Kolk from London. Thanks for some really useful presentations. I've also got quite a clinically focused question, which is about, beyond treatment, stimulants and psychotherapy, what reasonable adjustments would you propose for addiction services in treating neurodivergent patients? Because speaking in the UK, if we think about people with ADHD, addiction services require quite a high level of executive function to engage proactively in treatment. What do we need to change to meet the needs of these patients? And similarly, for autistic people, if you read through some of the NHSE guidance on adjusting mental health services for people with autistic people, a lot of those adjustments, like, for example, allowing the patient to choose the time of their appointment or wait in the car or things like that, really aren't implemented in addictions treatment. Addictions treatments are hugely strapped in terms of resources. What are the top priorities for reasonable adjustments to meet the needs of neurodivergent patients?
Julia, do you want to start with that?